Anaphylaxis diagnosis symptoms: malaise, weakness, sense of doom, prodromal, itching, swelling, and/or flushing of skin, nasal itch, congestion, sneeze, hoarseness, dyspnea, wheeze, chest tightness, cough, palpitations, headache, nausea, dysphagia, abdominal pain, cramping, bloating, anxiety, mental status changes. Signs: urticaria, red, elevated, non-pitting papules or plaques. Individual lesions are transient, 2 hours or less, and resolve without residuum. Erythema and angioedema, pallor and cyanosis. Possible: diaphoresis, nasal mucosal edema, rhinorrhea, edema of tongue, pharynx, larynx, stridor, tachypnea, chest wall retraction, wheeze, hyperinflation, pulmonary edema, bronchorrhea, pulsus paradoxicus, hypotension, tachycardia, arrhythmias, cardiac arrest, coronary insufficiency with ST wave changes in electrocardiogram, cardiac enzyme abnormality, vomiting, diarrhea, increased peristalsis, fecal and urinary incontinence, syncope and seizures. Investigations: immediate management period. Initial investigations aimed at management of acute system dysfunction but should not delay treatment. Search for causative factors, e.g., sting sites, in unconscious patients. Focused history to identify causative trigger and complicating conditions. Measurement of serum tryptase, mast cell protease, half-life about 2 hours in circulation, rise in histamine more transient and not helpful. Secondary laboratory abnormalities may be present: hemoconcentration, thrombocythemia, chest hyperinflation, elevated cardiac enzymes, ECG evidence for infarction, ischemia, or rhythm disturbances. Later diagnostic interventions: allergy evaluation, correlation of exposure with presence of allergen-specific immunoglobulin E, skin testing and RAST methods. Assess 14 or more days. Laterto allow for regeneration of antibody challenge procedures. Selected circumstances: under controlled conditions, urinary catecholamines and plasma histamine, when recovered, to investigate carcinoid syndrome and mastocytosis. Skin or bone biopsy, to confirm mastocytosis. Complications: failure to reverse progression may lead to severe consequences for major organ system function. High risk factors for mortality include cardiovascular collapse and asphyxiation. Prior blocker use complicates resuscitation treatment. Lifestyle management: patients should avoid proven and suspected triggers, have easy access to autoinjectable epinephrine, consider use of medic alert bracelet, and avoid blocker drugs if possible. Education of patient and responsible caregivers about trigger avoidance and emergency treatment is advised. Any chronic illness, especially pulmonary and cardiovascular, should be optimally managed. Pharmacologic treatment: immediate measures, standard dosage aqueous epinephrine 0.01 ml per kilogram subcutaneously, upper extremity, repeat up to twice at 20-minute intervals, maximum dose, 0.4 ml. For laryngospasm, consider nebulization of aqueous epinephrine, 0.5 ml per kilogram of 1:1000 diluted in 3 ml of normal saline. Maximum dose, 5 ml, 2.5 ml in patients less than or equal to 4Y, oracemic epinephrine, 2.25% solution, 0.05 ml per kilogram per dose, diluted in normal saline, maximum dose, 0.5 ml. Place patient Trendelenburg position, establish and maintain airway, giving oxygen as needed. Start intravenous line with normal saline, standard dosage diphenhydramine, 1 to 2 mg per kilogram IV, IM, or orally, if appropriate, to a maximum dose of 50 mg, repeat up to very 6H as indicated, 2 mg/kg/24H, maximum dose 300 mg/24H, ranitidine, 1 mg/kg/. Dose I.V, IM, or orally, if appropriate, to maximum dose of 50 mg, repeat up to very 6H as indicated, 5 mg/kg/24H, maximum dose 400 mg/24H, methylprednisolone, 1 mg per kilogram per dose I.V, IM, or prednisone orally if appropriate, to a maximum dose of 100 mg. Yields no immediate benefit, but reduces risk of recurrence or protracted anaphylaxis. Repeat up to very 6H, maximum dose 2 mg/kg/24H. For acute bronchospasm, administer standard doses of -2 agonists via aerosol delivery. Consider intravenous theophylline, treatment of hypotension aqueous epinephrine, 1:10,000, 0.1 milliliters per kilogram IV every 3 to 5 minutes for 2 to 3 doses, maximum dose, 5 milliliters. Consider IV infusion of 0.011.0 g/kg/min, titrated to effect. Consider dopamine infusion, inotropic effect. If fluid status corrected and epinephrine ineffective, consider norepinephrine, potent vasopressor. If unresponsive to fluid correction, epinephrine, and dopamine, treat ventricular arrhythmias as appropriate. Treatment of hypotension in patients using blockers administer isoproterenol, no agonist activity, via continuous infusion if responsive to epinephrine. Consider glucosin in refractory cases. Treatment aims to manage acute emergency, to identify trigger and initiate avoidance measures, and to monitor for protracted and recurring anaphylaxis, at least 12 hours. Prognosis excellent. If trigger avoidance successful. Follow-up and management encourage avoidance measures. Maintain emergency medication supply. Consult subspecialist as indicated. General principles: assess rapidly and establish close monitoring of vital signs and cardiopulmonary status. Maintain oxygenation, perfusion, cardiac output. Prepare for intubation or tracheostomy. Take clinical history to identify trigger. If possible, stop absorption of trigger with a venous tourniquet above reaction site, sting, injection, and administer local subcutaneous epinephrine, dose below, to delay absorption.